Hey there, this is going to be a introductory presentation on the diseases of the renal system. So in this presentation, we're going to cover some important terms that we'll talk about in our next few classes. We're going to review the function of the kidneys, and we will lead up to how we evaluate kidney function and sort of what can happen if kidney function is not working at full capacity. Here are your learning objectives. We'll do our best to identify these throughout the presentation. But getting started with some important terms, these are the collection of terms that we're going to refer to as the conditions or diseases relating to the renal system. So we have acute kidney injury or AKI. This is the short or sudden impairment in kidney function. Usually this can be resolved with proper medical and nutrition management. Then we have what's called nephrotic syndrome. This is characterized by the loss of protein in urine. We typically see hyperlipidemia and low serum albumin with edema. Now, nephrotic syndrome is not a type of AKI, but it can lead to an AKI. You'll notice that the low serum albumin is a common theme with our renal pathology. And the reason for this, or one of the reasons for this, is because when the kidneys get damaged, particularly in nephrotic syndrome, these sort of pores can open up on the kidneys, the nephrons, and those pores become large enough to allow albumin to leak or be filtered when they shouldn't be filtered. And then we lose that albumin. Albumin is a visceral protein that is important to our fluid and electrolyte balance. And so whenever we have low albumin, we commonly will see edema or fluid overload. Chronic kidney disease or CKD is the chronic kidney damage that is characterized by a low estimated glomerular filtration rate or eGFR for at least 3 months. End-stage renal disease is the progression of CKD. This is characterized as kidney function at 10 to 15% of normal. We also term this as CKD stage 5. We typically will be using a form of dialysis whenever we are in end-stage renal disease. And then finally, we have nephrolithiasis. Nephrolithiasis. This is, I'm sorry, I'm realizing I spelled that wrong. Nephrolithiasis is the other word for kidney stones. So what we're going to learn is that there are different types of kidney stones, and we can make some nutrition recommendations based on the type of kidney stones that are present. Now, we're going to talk a lot about substances or buildup of substances in the blood and in the urine. So generally speaking, when we have too much stuff, waste product, toxic materials, substances building up in the blood, that causes dysfunction of other organs. This is common in renal disease because we lose some of the filtering capacity of the kidneys. And so instead of taking some of these byproducts or toxic wastes out and dumping them into the urine, they stay in the blood. So anything you see with emia at the end is talking about something in the blood. The other terms you're going to see is the suffix of urea. Urea means in the urine. So at the same time, we can see excess substances being dumped into the urine or being filtered out of the nephron because the kidney isn't functioning properly. So basically, we can have too much in the blood or we can have too much being dumped into the urine. And that, of course, can cause problems. So azotemia is excess nitrogen or urea in the blood. If you remember, we get that nitrogen and urea from amino acid metabolism. And our kidneys work to help us get rid of that urea, that nitrogen. Hematuria is blood in the urine. Hypercalciuria is calcium in the urine. Hyperoxaluria is high oxalate in the urine, and this high calcium and oxalate in the urine can often lead to kidney stones or nephrolithiasis. Microalbuminuria is the leaking of albumin into the urine by the kidneys. This is often one of the first signs of renal insufficiency. And whenever we see poor albumin status, we already mentioned we often see edema, but something else that we also see is poor calcium status because albumin acts as a carrier for calcium. One of the themes that we're going to discuss when we get to CKD is the connection between renal insufficiency and bone disease. So think about this and put that in your back pocket. Oliguria is the little urine output about 500 milliliters of urine output or less. Anuria, which I will add, means less than that, or 0 milliliters urine output. So their kidneys are not making any urine. And then proteinuria just means high protein in the urine. So instead of reabsorbing those proteins, our nephrons are filtering them out and dumping them into the urine. Now, whenever kidney function goes south, we do have some medical treatments available to help our patients. You've probably heard of dialysis. This is a form of renal replacement that acts as the kidneys, but uses some type of machine or dialysate to remove the toxic byproducts from the blood. And in doing so, it just replaces the filtering function of the kidneys. There are two major types of dialysis. There's hemodialysis and peritoneal dialysis. Basically, the difference here is that hemodialysis uses a machine with a semipermeable membrane, as well as dialysis fluid to filter the blood instead of the kidneys. Peritoneal dialysis, on the other hand, uses the person's peritoneum as the semi-permeable membrane. And so the dialysate is actually put into the peritoneal cavity, and a machine isn't used outside as the filter. So the body is being used as the filter. Now, we'll talk about the merits of hemodialysis versus peritoneal dialysis when we get to end-stage renal disease, but understanding the two differences, the main differences there is important. And then finally, there's CRRT, or continuous renal replacement therapy. Think of this as a really like high level dialysis. This is reserved for our patients with AKI, or acute kidney injuries, or usually they have multiple organ failure or they're hemodynamically unstable and can't tolerate hemodialysis. So CRRT is typically going to be performed in a critical care unit in the patient's room, and they may be on this for 12 hours at a time, whereas hemodialysis is usually 3 to 4 hours on a machine. CRRT is for an extended period of time. Now, that is going to affect, or each of these different forms of dialysis is going to affect the patient's nutritional needs. So whenever we get to that part of our lecture, we'll discuss the nutrient demands for that. Now, we're going to talk about CKD because it is highly prevalent in the United States. And we typically see that the primary causes for CKD are hypertension and diabetes, especially. Now, we've talked about this a lot in class. When we have high blood sugar, the blood becomes more viscous and it can lead to more damage in our small little vessels and capillaries. Now, where do we have all of those small vessels and capillaries? One of the main places is our kidneys. So those capillaries that help with filtering and reabsorbing become damaged, and therefore the functional capacity of the kidney declines. Now, stage 2 to stage 4, which you see here, we typically refer to as chronic kidney disease. Generally speaking, when someone has chronic kidney disease, we like to lower the protein load on the kidneys because higher protein puts a little bit more stress on the kidneys because of that nitrogen component of amino acid metabolism with monitoring electrolytes. So we commonly see calcium, potassium, phosphorus, particularly, and sodium becoming out of balance. And dietitians have to closely monitor those electrolytes and make sure that we are helping patients to maintain normal serum electrolyte status. Now, once we reach stage 5, kidney disease, aka end-stage renal disease, this is whenever we see patients start dialysis. And because of the demand of dialysis on the body, this typically translates to higher protein needs for our patients. Some liberalization in fluid or electrolytes, possibly, but again, all of this depends on the patient's lab work. Now, let's take a couple of steps back and look at exactly what the kidneys are supposed to do. So, mainly, kidneys are supposed to make ultrafiltrate, which the glomerulus is in charge of. The glomerulus is the filtering hub of the nephron, which is the functional unit of the kidney itself. In the glomerulus, whenever we are making ultrafiltrate, we are working to reabsorb a large amount of sodium and water. And if you remember correctly, by reabsorbing that sodium and water, our kidneys are helping to maintain normal fluid and electrolyte status. So you can see if we lose that functional capacity of the kidneys, then fluid and electrolyte status can get way off. A lot of times we're going to see excess fluid reabsorption, where the kidneys can't get enough fluid out. So we'll see a high weight gain, and edema, and that can affect our serum electrolytes as well. The glomerulus is also important for filtering large proteins and blood cells. So this is where we start to see like albumin come into play. On top of that, our kidneys are meant to excrete metabolic end products and foreign substances. So the metabolic end product example is ammonia or urea. Foreign substances example is drugs or medications. So at normal health, our kidneys should be able to help us get rid of those toxic byproducts. In dysfunctional kidneys, that's not possible. And so these can reach harmful levels in the blood and cause systemic problems for patients. On top of that, our kidneys help to produce certain enzymes and hormones. They work with the renin-angiotensin-aldosterone system, which you see here. Some important things to remember is that with the RAS system, the liver, the kidney, lungs, adrenal cortex, all of these are working together to maintain normal fluid and electrolyte status. Now, I've highlighted a few important terms or hormones that you might remember. So aldosterone is what is responsible for telling the kidneys to reabsorb sodium. And if you follow that, so aldosterone works on the kidneys. That tells the kidney to reabsorb sodium. That means we conserve sodium in the blood, and that means we hold on to more water in the kidneys. So it helps to correct a low blood pressure or low fluid volume. Vasopressin also works on the kidneys to, again, increase reabsorption of fluid by the kidney tubules. So again, vasopressin helps to conserve water in the blood, and then helps to improve fluid and electrolyte status. Now, with this, the kidneys play a major role in acid-base balance. If you want to have a refresher of acid-base balance, you can take a look at this video from the lecture slides. A little bit more about the anatomy of the kidneys. We have heard over and over again that the functional unit of the kidney is the nephron. So here is the kidney. We often refer to the renal cortex, which is this outer layer, and then the renal medulla. But right here is our nephron, which is the functional unit. And here is the expanded look at the nephron. So some important terms with our nephron is that we have two main arterioles within the nephron. The afferent arteriole carries blood to the glomerulus, which is the filtering body within the nephron. So it brings blood to the glomerulus to be filtered. And then whatever has passed or is carried away from the glomerulus leaves the glomerulus through the efferent arteriole. So a closer look here, we have the afferent and the efferent, and here is our glomerulus. So we push blood through the afferent arteriole into the glomerulus. The glomerulus filters, okay, and then the blood leaves through the efferent arteriole. Now, some other important terms are our proximal tubule, our distal and um, our distal tubule and collecting duct, and then the loop of Henle. You can see here the importance of each of those. Our distal tubule and collecting duct are what are primarily responsible for sodium and fluid, as well as potassium levels. Um, so if we have issues with fluid and sodium and potassium levels, we can pretty much infer that the distal tubule and collecting duct are the issues. Here's just another look. The afferent arteriole brings blood towards the glomerulus. The glomerulus filters that blood. If the glomerulus decides to put something into the urine or to filter it out of the blood, then it leaves the glomerulus and enters the Bowman's capsule and moves through the Bowman's capsule into the urine. If the glomerulus decides to reabsorb something, reabsorb means it stays in circulation. It leaves the glomerulus through the efferent arteriole and moves back to the circulatory tract. So what you have to know is the glomerulus is our filter. If we decide to filter it out, it moves through the Bowman's capsule towards the urine. Efferent brings it to the glomerulus. Sorry, afferent brings it to the glomerulus. Efferent makes it leave the glomerulus, the blood. Now, how do we know if the kidneys are not functioning properly, or how do we know that the kidneys are functioning properly? We can do several tests. The first that we can do is a urinalysis. Are we seeing microalbuminuria? Are we seeing albumin in the urine? This is a protein. Again, this is one of the first signs of renal insufficiency. We can also do a clearance test, typically measured by the glomerular filtration rate or estimated GFR. We often will see a variety of blood tests drawn on a renal panel. But we can also do some radiological evaluation or biopsies, other types of things. But this is the typical renal panel, blood panel that we'll see. So first you'll see sodium, potassium, chloride, bicarbonate, phosphorus, calcium. Again, this is fluid, electrolyte, acid-base balance. Are all of these things in good favor? If not, then we might have a problem with the kidneys. Glucose levels, because we can see some issues, especially with our patients with diabetes, can be a factor in poor renal function. Blood urea nitrogen is the measure of nitrogen in the blood. Where do we get nitrogen? From amino acid metabolism. So it's natural that if we have a really high protein intake, our BUN can be a bit higher. However, when we cannot filter out urea or the nitrogen ammonia waste product, then the BUN will get higher because there's more urea that the kidneys are not able to filter out and push into the urine. Creatinine is also going to be impacted by renal function. Albumin, we typically see albumin is low in our patients because we have that leaking albumin through the nephron. Our GFR becomes reduced as kidney dysfunction progresses. The glomerular filtration rate, so how well are the glomeruli working? The lower the number, the worse the renal insufficiency is. So this is your standard renal function panel. We're going to do lots of practice with this in our case studies. Now, the other thing I wanted to mention is the connection between bone disease and renal insufficiency. So when we have damaged kidneys, we commonly see that our calcium and phosphorus levels are off because we have low albumin, which is a carrier for calcium. We tend to see low serum calcium. And we also see higher phosphate or phosphorus levels in the blood because phosphorus can't be filtered out of the kidneys sufficiently. So, what happens is the parathyroid gland secretes parathyroid hormone in an effort to increase serum calcium levels. Now, if you remember, the parathyroid gland is the major organ that is responsible for our calcium levels. So PTH helps to increase calcium levels. Now, what can happen though is that the more PTH that we secrete, okay, we see lower levels of calcitriol, we see higher bone turnover, and we see reduced renal reabsorption. Now, what does that mean? Our bones start pushing out more calcium, which can damage and make the bones more brittle. Okay. But then we have decreased reabsorption. So then more calcium leaves the urine. And we still have poor functional capacity of the kidneys to filter out phosphorus. So, all of that to say, we can see greater decrease in calcium coming from the bones and a greater increase in phosphorus availability in the blood. Now, what that can cause is more stress on the parathyroid gland. So we can see parathyroid hyperplasia. And whenever the thyroid gland becomes dysfunctional because of that hyperplasia, we see what's called secondary hyperparathyroidism. Now, that means if the parathyroid gland can't do its job to regulate calcium levels, then that can lead to what is called renal bone disease or osteoitis fibrosa cystica. This is the specific renal disease that we see in patients, the specific bone disease that we see in patients with renal insufficiency. Okay, so that's going to wrap up our first presentation. Next presentation, we'll get into chronic kidney disease specifically.